Already, in the interest of time and ensuring that we end on time today, we'll go ahead and get started here. My name is Aaron Higgins. I'm with Strategic Healthcare Partners. I will be your moderator today. So, good afternoon and welcome to the No Surprises Act legislation webinar. But before we get started, there's a few housekeeping things. I'm sure you've heard these before, but we got to go through them just because these are commonly asked questions. First off, and most importantly, the webinar will be recorded. We will be posting it to our website, hopefully later today, but with the holiday season, it may be delayed. And we will also have a link to our slide deck posted there as well. So if you want to just go through the slides, you'll be able to do so. Our website is shp.com, or sorry, shpllc.com/webinars. Second off, you may have noticed you are muted. If you do have a question at all during the presentation, you can ask it in the chat at any time. If your question's more complex and you want to ask it out loud, you can raise your hand in the Teams app and I or another moderator will unmute you and you can ask your question that way. We will have an opportunity towards the end to ask questions. So if you want to save it till then, that's fine as well. Now, I'm going to turn the presentation over to Michelle Madison. She is with Manning Morris and Associates, and she needs very little introduction. So, Michelle, I turn it over to you.
All right, thank you. Let me see if I can show. Oh, great, you got my slides. So if we can go, can I just ask you, Aaron, if we'll go to the next one? That's great. So I want to start this presentation by saying this law is a federal law that we're going to talk about today. There is a state law as well. The provisions that are contained within this law are incredibly convoluted. So there are nuances to it that impact every little part. So this presentation is really intended to provide you with the education about what the laws require. There were two different sections of the law that were published by the federal government, one in July and then another one in October. So we're going to talk about both parts of the law because both parts become effective on January the 1st, 2022, unless this lawsuit that's currently pending pushes back the enforcement date. So if we can go to the next slide, I'm going to talk about the lawsuit in just a few minutes. But basically, the concept of the federal law is very similar to the state law. So if you are a Georgia provider online today, Georgia put in place a No Surprise Billing Act law that was effective as of January 1st of this year, 2021. The federal law goes into effect in 2022. There are some differences between the two laws, and I'm going to talk a little bit about how they apply and where one exempts the other. So surprise billing is basically what they're trying to do is to protect the patients that go to, let's say, an emergency department of a hospital, and the hospital is in network, and let's say their payer is Aetna. So the hospital is in network with Aetna, but the emergency room group is out of network with Aetna. And so the patient is seen in 2020 in Georgia. That meant that the patient would have received a bill from the hospital and then a bill from the emergency room provider. The emergency room provider may have billed them their total charges, where the hospital would have billed for their contracted rate. And so that balanced billing of the full charge and being surprised by that is what the federal government is trying to protect patients from. So let's go to the next slide. The concept that we're going to talk about is really when you have a non-participating provider at a participating facility, or for emergency services, you have a non-participating provider or a non-participating facility, and that's how this federal law will apply. And what do I mean by non-participating? It means they don't have a contract with that healthcare plan or that insurance plan. So that's when I say non-participating, that's why. I do want to remind everybody that the federal law requirements do not apply to federal programs. So this does not apply to Medicare, Medicaid, Indian Health Services, VA, Veterans Affairs, or TRICARE. All of those different payer plans have other protections. So this law does not apply to those plans. Let's go to the next slide. So I mentioned that they split it up into two different parts. So let's go to the next slide. I'm going to focus for the first part of this presentation on the first part of the rule that came out in July of 2021. And one of the questions I got earlier this week was, who in the world does this apply to? So the way they have worded it is that it applies to emergency departments of hospitals. It applies to independent freestanding emergency departments. It applies to what they call healthcare providers, which is very broadly defined as a physician or a licensed healthcare provider that's acting within the scope of their state license. So your docs, your therapists, mid-levels, and then healthcare facilities. And that includes hospitals, it includes critical access hospitals, ambulatory surgical centers, and a hospital outpatient department. Now, remember, when we talk about the services, we're talking about both emergency and non-emergency services. So for some of these providers, like an ambulatory surgical center, you really shouldn't have emergency services unless something has gone wrong. So that's really more of a non-emergent service application there. And then the providers of air ambulances. And I don't know if anybody on the line operates an air ambulance, but when you read the preamble to these rules, that was one of the providers that caused them such focus. It was the emergency room providers who were not participating in an insurance plan, but the hospital was in the insurance plan, so the patient went there, then got a balance bill, or the patient had to present to was in an accident and the air ambulance picked them up and transported them to the facility, and the size of the bills that they were seeing those patients get was just crippling from an economic standpoint for those patients, and that's why they made special provisions in this No Surprise Act for air ambulances. So let's go to the next slide, please. So we're going to talk about emergency services first. So if you're a physician online and you are on call and the hospital calls you and says, I've got a ENT patient, emergency situation, I need you to come in and help with the emergency medical screening, and that hospital is in Aetna, but you're not a participating provider in Aetna, then this rule would apply to those emergency services that you are rendering at that hospital. So the way this works is if a patient presents to an emergency department of a hospital or to an independent freestanding emergency department, then if you are out of network, you're not allowed to balance bill the patient your full charges. You would bill the patient only for their in-network cost sharing requirements. So if I'm a patient and my in-network benefits on my health plan, say I've got a copay of $100 for a hospital visit, or I have a cost share where I have to spend up to 10% of the total bill, then that is my that's my responsibility of what I'm going to get paid from the patient. And then when I bill the insurance plan, they are only required to pay me a certain amount, and it is not my balance charges. So we no longer will be balance billing patients for those emergency services out of the facility or from the provider. There will be a set in advance methodology for the purposes of determining what we're going to get paid. So let's go to the next slide. This is a slide that talks about the federal law. So I want to stress this slide is federal. So before my example, patient presents to the hospital, doctor comes in and sees the patient. Doctor is not a participating provider in that insurance plan. They would only be able to bill the patient their in-network cost sharing amount. And then the insurance company will pay you one of three amounts under the federal law. If there is an all-payer model agreement, which means CMS has these all-payer model agreements with a few states, not all states. If one existed, they would look to that payer agreement to determine what rates apply to the CPT codes that you billed for, and that's what they would pay. If there's no all-payer model agreement, then they're going to look to the state law. And in Georgia, our regulations for emergency services, when you are a non-participating provider, goes into one of three buckets as the reimbursement rate. It's either the verifiable median contracted amount that all eligible insurers for similar services pay in our state, and that comes from a vendor that the Office of the Insurance Commissioner was supposed to contract with. There's a whole other story behind that, where that is a data point today, but maybe not an actual all-payer database. It does not appear that the state actually contracted for a full all-payer database. So then the second alternative for state reimbursement is if you previously had an in-network agreement with the insurer. So if you used to be with Aetna, then whatever you got paid under your old agreement is what they could pay you. Or the insurance company could decide, hey, we're going to pay you more than what that all-payer or that database would have provided or what we provided under a previous agreement, but that would be within the discretion of the insurance company. So that's the state law of what they would pay. And then let's jump back to the federal law for a second. So let's assume there's no all-payer model agreement and the state law rates are loosey-goosey and there's not really a state law rate. Then the insurance company would pay you what's called the qualifying payment amount, which is the average, it's the lesser of your bill charges or the median contracted rate, not the average, the median contracted rate of what they contract with other providers for that same or similar service. So if you bill, let's say, 99215 for the visit that you had in the emergency department, but you're not a participating provider, the insurance company could say, well, for all other providers that we do contract for, the 99215, we pay $500. So that's what we will pay you. That's the median contracted amount. If you disagree with one of those three methodologies of payment that the insurance company uses, there is an appeal process you can follow, and I'll talk about that because it came in the second wave of the rules, which was in October. So if we can go to the next slide. So I just told you how you can't balance bill for emergency services and how they're going to reimburse you and what they would pay you for. In the regs, there is this carve out. And as I mentioned, these regs are very different. So there is a carve out that says you can balance bill for emergency services if, so this is a very unique situation. I rarely see this ever happening. But let's say patient presents to the hospital, you're stabilizing them, you stabilized them, and the admitting emergency physician or treating provider determines that this person is stable enough, now that we've done the emergency services, that they could actually, using non-medical transport, so not an ambulance, be able to travel to a participating facility or site that's in a reasonable distance. We can't say, oh, they're fine, they can travel 300 miles to get to the next place. It needs to be a reasonable distance, which they don't define by the rules. And then you have to give them an informed consent saying you were able to have reasonable travel and we think that you're stable enough to go to a participating provider. Here's the list of the other places that have participating provider. And here is a good faith estimate of the amount of money that it would cost for us to continue to provide these services to you. In this instance, let's go to the next slide, the patient would have to be in a condition to be able to make an informed consent, so to understand the risks versus the benefits of getting in a non-medical transport and going somewhere else for a participating provider. And then you'd have to sign the consent that, yes, I agree. If they stay, they'd have to sign a consent that says, yes, I want to be treated by a non-participating provider here, and I've received a good faith estimate of the charges, and I'm going to stay here for services. So this is an odd dynamic in the regulations. I don't see it happening a lot. The more prevalent rule is if you're there for emergency services, the emergency services and any other services that are related to those emergency services, which could include post-stabilization services, should just not be balance billed. You bill the in-network cost sharing amount and you get paid under that insurance model of one of those three rates. This concept of having a physician determine a patient can be transported and then you give them these informed consents and you list all the other providers is something that I think is going to be a very limited use methodology. Let's go to the next slide, please. So now I'm going to flip from emergency services. So what we just talked about are emergency services, which includes patient presents to the emergency department and can include the ancillary services that they receive post-stabilization following that emergency room department visit. Now and so in those instances, we do not balance bill. We get their in-network cost sharing amount, and then the insurance company pays us the amount under one of those three methodologies. Now I'm going to flip you to non-emergent services. So this is, I'm a non-participating provider in the health plan. The patient is going to a participating provider location for a service, and I should not balance bill unless I provide a notice to the patient and I get their consent. And there are model forms that CMS has published, and I'm going to send those to Aaron so he can send it out to everybody who is on this call today. Because in all honesty, when I look at those model forms, the regulations recommend that you stay with the language of the model forms. And there's some little places, brackets, where you insert unique information for your facility or your provider, but just keep the language from the form because that's what CMS has adopted. That's what the federal government has said complies, and that makes it a lot easier on the facility. So there are instances, though, when there are non-emergent services where you can't even get an informed consent and provide notice and be able to actually balance bill the patient. So let's go to the next slide.
And quick, Michelle, this
Yes, sir.
applies to all payers, right?
So this applies to any group and individual health plan and all ERISA plans and any grandfather plans under the Healthcare Reform Act. Yes.
Got it.
Mhm. So the consent and notice. So think about elective surgery. This is my best example of being able to give notice and get consent to be able to balance bill a patient. For some post-stabilization services, and I'm going to show you a slide in a minute on some services that you cannot get consent and notice for, that you're just going to be restricted to in-network cost sharing only. But for some post-stabilization services that are not emergent, so not the stuff related to the emergency room visit, but more just treatment services that are not emergent, you could provide the individual patient with a notice that there is a federal law that protects you from balance billing. Here, we are going to provide the services to you. We are not participating providers in your insurance plan, and we are requesting your consent to waive the balance billing prohibitions and allow us to bill you for the services that we are rendering. And you give an estimate with that consent and notice. And this is the one where there is a federal form that I recommend that you use that form and try not to deviate from it. So let's go to the next slide, because this is where all kinds of confusion arose. So I just talked about the fact that you could have non-emergent services where you give the patient notice, you get their consent, which I'm going to go through in detail in a moment, and then you can balance bill them. Well, then the law has an entire exception that says no matter what, even for non-emergent services, you cannot provide a notice and get consent to balance bill a patient for these items. So they're items that are related to the emergency medicine service. So if I come in the emergency department, you stabilize me, but I had to have a procedure done and the anesthesiologist was there and they did a biopsy and sent it to pathology and the radiologist did a CT and an interpretation. And let's just say that a mom comes in with a child and a neonatologist is involved. Even though those may not be emergency services because it was post-stabilization, you cannot balance bill for those services with a notice and consent. You are restricted to that in-network. If you're out of network, you're restricted to that in-network cost sharing. The other area where you cannot get notice and consent is for assistant surgeons, hospitalists, and intensivists. And what the government said here is, these are the types of services where the patient comes in for a service, but they're not expecting to have direct billing relationships other than they know they're going to get a bill because they're independent contractors. There's not time to get a notice and consent for these kind of ancillary services that are ancillary to the main primary service that person came in for. So you can't do notice and consent on those services. And then radiology and lab, this was a big question last week, was, well, how does this apply to radiologists? You cannot do notice and consent on radiology and laboratory services. You have to take the in-network cost sharing amount and the payment methodologies under the federal law. And then let's say that I'm a patient and I come to the hospital and I have a non-participating provider who I'm not in emergent condition. Emergency medical screening says that I have a cold or the flu and it's not emergent. And this doctor is there to see me, but he's not in network. If there are no other participating providers in my network at the facility, then they can't give me notice and consent to accept the balance billing because there's no other participating providers that I would have had a reasonable chance to choose to get services from. Because I am only allowed to get services from a non-participating provider, then that non-participating provider is required to only bill my in-network rates. So, or the rates that the insurance company pays under one of those three methodologies. And then last but not least, if there is an urgent medical need that's unforeseen, and my thought on this, and it's not an example in the regs, but my thought was like you go to an ambulatory surgical center, which is governed by these rules, and something happens during the case, and now it's an urgent emergency situation to save the patient's life, the notice and consent for balance billing wouldn't apply to that urgent delivery of service. So this has been very confusing because normally the rule would be, for non-emergent services, if you provide the notice and you get the consent from the patient, you could balance bill, except for all of these services. So any of these services, you cannot do the notice and consent. So let's go to the next slide. I just want to give an overview of what that consent looks like. The consent is going to come from a non-participating provider, or if the hospital's emergency department is non-participating, if it's not then it's post-stabilization services. So you're not in an emergent medical condition anymore. You have given notice that the services are non-emergent. Here is your good faith estimate. Here's your notice. Here's your consent. And that consent has to be given at least 3 hours before any other services are rendered. Then you could provide that consent for those post-stabilization non-emergent services. Or if there's a non-participating provider doing non-emergency services at the hospital, you could do the consent except for those items that we just talked about on the slide before. And then the standard notice and consent documents need to be a separate document from your regular consent. So remember, under HIPAA, we can't combine the authorization to release information with other documents. It needs to be a standalone document. They want the same thing here. They want the notice and the consent to be standalone documents so that the patient has their focus on those documents and it's not buried inside of another document where there's not a full informed consent. The notice has to be provided on paper, so you can do it either electronically or in paper, but if you do it electronically, that person must have some mechanism to be able to save it or print it so that they'll have a paper copy. And then if someone says, hey, I'll give oral consent, we've got to have a signed consent that is documented in person or by mail so that it's on the records, because these consents, and you'll find out later in our presentation, the good faith estimates all stay on the medical record. So let's go to the next slide so we can actually talk about these consent elements. The elements from the government are, remember, they have a model form, and I highly recommend the model form, is that it has to be clear, understandable language. So remember, under Section 1557, if you have individuals who are prevalent in your facility who speak other languages, we also have to make sure that it's translated into those languages. The enrollee has to have been provided, enrollee being that patient or that insurance enrollee, has to have been provided written notice that their payment that they're going to pay under this balance billing may not accrue towards the plan cost sharing or deductible, and that the actual patient could be giving consent to a balance bill that they may not get credit for from their insurance plan. When you do the in-network cost sharing part under the emergency services, by law, that does go towards their deductibles and their copays on the in-network side. The consent also means that the patient is saying, yes, I'm willing to be treated by a non-participating provider and I'm going to be balance billed. I understand that. Remember, this is non-emergent services. And then we have to document the date and time when they got the notice and the date and time when the consent was signed. In Georgia, for some reason, the statute about consent says that the patient has to give written consent and oral consent. I don't know if that law will change later, but it is an and not an or. So it's written and oral. So making sure you have that discussion after the patient has signed their consent. But let's talk about the timing of consent. Let's go to the next slide. So if somebody makes an appointment, so let's say, again, not radiology, not lab, because you can't do consent and notice on those, but let's say that I'm going to have Mohs surgery and I'm going to schedule that visit. Then when I go and make an appointment for that visit, at least 72 hours before I'm supposed to have that visit, the notice and consent document should be provided to me. So either electronically or in writing. And if it's on the day that the appointment is going to happen, then I need to have it 3 hours before. If I'm in the hospital and I have been stabilized and the hospital has decided that they want to balance bill me for post-stabilization, so I'm already stabilized and the hospital says, hey, we want to balance bill for post-stabilization, then you have to give me that notice and consent at least 3 hours prior to furnishing any of those post-stabilization services, which is why I don't see that happening a lot. Because usually you go in, you have emergent services, and then you're either moved to an inpatient and you're going to continue services, which would be considered inclusive or of emergency services, or I'm going to go into observation until I'm discharged, and those services to then stop, give me notice and consent because it's post-stabilization, and making sure I go through all the requirements that are required would be somewhat difficult. Most facilities, or I shouldn't say most, some facilities have talked about just treating emergency services from that visit when they walk in the ED all the way until they're discharged, and then not balance billing, but going through that in-network, and then the 3 methodologies of insurance reimbursement provided by federal law and state law.
Michelle, I don't know where this question goes, but this seems like it's in the context of a doctor has already made an order for this, and it's a specific treatment. If somebody is really just price shopping, which is sort of part of the point, how does this apply to that? They're not going to have a diagnosis code. How does that apply?
So that's going to go to the good faith estimate part that we're going to talk about in a little bit.
Okay.
And that was in the part 2 of the rules in October. But there are things called co-providers and then convening provider. And then there's 3 business days after somebody asks for an estimate to have to respond to that. And they could ask for it from any one of those providers, the co-provider or the convening provider. So when we get to that good faith estimate section, I'll make sure we spend time to walk through that process. Does that work?
Got it. Thank you. Don't get out of work. Yep. Thank you.
All right. So let's go to the written notice requirements. That's the next slide. So I talked about consent. There are 3 different documents that you need to know about under the federal law. There's the consent, there's the notice. So the notice goes to the patient and it's in writing and says, healthcare provider is not a participating provider. Here is the good faith estimate of what we may charge the patient for the services, participant being participant in insurance plan. That the prior authorization may be required, because remember, I'm talking non-emergent services now. I'm giving you the estimate of what our fees may be, and that estimate includes all other items, supplies, and services related to that procedure. And I am telling you that I might have to get prior authorization, or you, patient, might have to get prior authorization before we can deliver this service. And that when you consent, you are consenting to a non-participating provider providing the service, and you always have the option to go and receive care from a participating provider. So if you're sitting there thinking, gosh, I've got to create another document, this notice document is included with the model consent document that the federal government gave us. So it's already drafted. We just need to modify it for the facility. So let's go to the next slide, please. These next 2 slides are really just kind of summary of the surprise billing concept. So bands billing for emergencies, balance billing for emergency services, you get cost sharing on an in-network basis. That in-network from an insurance plan standpoint must be applied to their network deductible or cost sharing responsibility if it's an emergency service. It prevents or prohibits out-of-network charges by a provider unless notice and consent are given, or if it's one of those services that you're not allowed to do notice and consent, you're stuck with the in-network cost sharing and the reimbursement rates provided by federal law. Let's go to the next slide. And again, emergency and non-emergency services, there's that cost sharing of the in-network. And if you dispute the payment that you receive from the insurance company, the second phase of the rule, surprise billing part 2, provides an independent dispute resolution process that I'm going to talk about later. Okay, let's go to the next slide. Remember, I said there were 3 documents that I wanted you to be aware of on the federal side. There was the notice, the consent, and now there's this disclosure. Government gave us the disclosure form, so don't worry, we have it, and we'll just modify it for the facility. But you literally put it on your website, and the providers, physicians, need to put it on their website. If you don't have a website, then you publish it in your office in the same manner that we used to and still do. Put the HIPAA notice of privacy practices, you know how we framed them and they look all pretty next to our registration desk. This is the same thing you do here. You'd post the disclosure next to the registration desk when somebody does their scheduling. Otherwise, you put it on the website. And we have to provide this disclosure to the patients either in person, by mail, or via email. And it has to be limited to 1 page, double-sided in font 12 or higher. And the whole concept there is this is telling the patient about the balance billing prohibitions under federal law and what their rights are related to balance billing and in-network or out-of-network reimbursement rates. So that's the key part related to this disclosure form. It's really all about patient knowledge and informing them of what's going on. So let's go to the next slide. So now I'm going to jump into part 2, which came out in October. We can go to the next slide. I'm not going to spend too much time on this because it's a process that's just kind of regimented. So the independent dispute resolution process, if you dispute what the insurance company paid you, then you can negotiate with them for about 30 business days after you receive that first denial or that payment. It is more important today than ever before that if you're using a billing company or your revenue cycle management team, to make sure that if they dispute an out-of-network reimbursement under the federal law or the state law, that they file that dispute resolution request within that 30 business days. because if you miss it, somebody could argue, well, you missed the deadline, your arbitration or your claim for dispute resolution is out. So very important to watch your business days. Once the open negotiation doesn't work within those 30 days, you give a notice within 4 business days of the end of that 30 days for the dispute resolution. Then you're both supposed to select what's called an IDR entity, an independent dispute resolution entity. And one of the questions I got was, well, can you send me a list of all those entities? Well, unfortunately, the way you find out who those entities are is you have to go through the CMS portal and register as a provider to get the list. And there are companies that apply to CMS to be an IDR entity. And then once they apply, you can comment on them, but once they're approved, they'll be in the portal. So when you go into the portal to request IDR review, you can then select an individual entity. If you and the insurance company disagree on an IDR entity, the government can appoint one within 10 business days after the submission. And then there should be a binding determination of which rate they're going to go with within 30 business days. And then 30 days after that decision is when the payment should be issued to you. Now, here's a big problem. Let's go to the next slide. Under the law, the presumption is that the proper rate of reimbursement is that qualifying payment amount, which remember from our earlier slides, is the median contracted amount that the insurer has with other providers for same or similar services. So this is where that lawsuit came in that I'm going to talk about later. AHA and AMA said, well, this is ridiculous because now the insurance companies are going to be motivated to negotiate the lowest rate possible, so their median rate is so low. And then when you get into the IDR process, you're already losing because the rates are so low that their median contracted rate is going to probably be below what we would normally accept. And therefore, there's a presumption to favor the insurance company and to force lower rates in the marketplace. So they've asked for an injunction to stop the enforcement and implementation of this law, which is supposed to go into effect on January the 1st of 2022. And they're trying to stop the implementation until this IDR process can be modified or addressed further. So there's not this presumption of favorability to the insurance companies. Let's go to the next slide. So now, Mike, we're kind of getting into that good faith estimate. So in that second phase of the surprise billing, there were 2 main parts, the IDR part and the timing and how that process works. And there's a lot more to that. It's 114 pages of regs. And then there's a section on good faith estimates. And so this applies to uninsured patients. So these are patients who have no insurance, or their insurance doesn't provide coverage for the benefits that they are seeking services for, or they elect not to assign their benefits to you for those services. Because remember under HIPAA how we have that provision that if I want to pay fully for my visit, I can pay for my visit and you can't bill it to my insurance company. I'm not reassigning my billing rights to you. So they could do that and become an uninsured patient. When you have an uninsured patient, we are supposed to provide them with a good faith estimate of the charges that we would charge them for an item or a service. So in that instance, what happens is, let's go to the next slide. We would inquire from the patient, what's your insurance status? Are you assigning benefits? Yes or no? Do you have insurance? Does the insurance cover this? And then once we find out whether or not they are insured or uninsured, if they're uninsured, the self-pay concept kicks in, and we provide them a good faith estimate of the expected charges, which includes the item or service that they're going to receive from us, including all the other ancillary services related to it, which makes it very difficult. So let's go to the next slide. This good faith estimate form, and when you look at the consent model form under the federal law for the other services, it has an estimate box as well. But the good faith estimate has to be clear, understandable, prominently displayed, and it has to have the convening provider or the convening facility's website. So what in the world is a convening provider or facility? That's where the scheduling is happening. So if they are going to have, let's say, surgery at my facility and I'm a hospital, then when that patient calls up or the registration person calls up to schedule that appointment, the hospital is now the convening provider. And so when you look at that surgical procedure, I'm going to have the surgeon, I'm going to have all of these other supplies and services that are associated with the surgery. So the convening provider has to convene the good faith estimates from the other providers into this document to give it to the patient. So the convening provider would work with what's called a co-provider. That's the person or entity that's going to provide part of the service but didn't actually schedule the service, and they need to give their good faith estimate within 1 business day of getting the request from the convening facility. And then the convening facility puts together the good faith estimate and gives it to the patient. It has to be done in writing. It can be done orally if the patient requested orally, but you have to follow up with it in writing to them as well. It also has to be in all those different languages that our patients speak. So the other important thing to know is that if I'm a co-provider, so let's say I'm the surgeon, and that patient not only calls the hospital to schedule their surgery on Tuesday and asks for the good faith estimate, but they also call my office and as the surgeon and ask for my estimate, I also have to give an estimate. So just remember the goal, and HHS has specifically said they want one convening provider to get all the estimates together and give it to the patient to stop any undue burden on the patient. But if a patient starts asking for good faith estimates from everybody, then the patient will be getting good faith estimates from everyone. So it's a little confusing there. Let's go to the next slide. The good faith estimate. I'm sorry. Go ahead, Matt. Mike.
So Michelle, when a hospital is involved, is the hospital almost always going to be the convening provider?
It's not always. I mean, I think if you look at the types of services that are non-emergent going to be scheduled, more than likely, yes, unless the physician office is scheduling everything on behalf of the patient. And then sometimes they do that. So for our hospitals that employ their providers, it's likely the hospital is going to be the convening party. If it's a non-employed physician office, but that their registration person does all the scheduling, including scheduling in your block scheduling at the hospital, then that could be the convening provider. And if you're not sure who the convening provider is, then there's always co-providers, and you could both give them an estimate. I did not see any penalties for saying, oh, well, we thought they were the convening provider, but it is important that the providers communicate with one another. So if the provider in an independent physician office is actually doing all the scheduling and the hospital sees them as a convening provider, they should give their good faith estimate to that physician practice to include their good faith estimate in that. And then my suggestion would be that the hospital also request a copy of what good faith estimate was provided to the patient, so they have it on file as well, because your co-providers and whoever the convening provider is should be communicating and coordinating that communication between all providers and the patient. So that should avoid any penalties.
Got it.
But it's not always the hospital. So this example on this slide is directly out of the regs. So basically, the good faith estimate has to include all the expected charges. And this is one where there's surgery. And so they say you need to include the cost of the surgery, any supplies and services related to the surgery, any pre-surgery appointments or therapy that are before or after the surgery are not included. It's related to the items or services that are going to be rendered at the time of the procedure. So labs, tests, anesthesia costs, those types of things. So that would all be in that good faith estimate. It's not just going to be, oh yeah, our facility charge for that surgery is $500. It won't be that. It'll be everything. Let's go to the next slide. I did want to mention HHS is aware that doing these good faith estimates is going to be very time consuming and difficult to initially implement. So they have reserved enforcement discretion from this upcoming calendar year. So they will be monitoring it, and they're reserving their discretion as to whether or not they would have any enforcement activities if somebody's good faith estimate process was just completely lacking. We do need to make a good faith effort to have a good faith estimate that includes all the items or services. We need to try and make sure that we're complying, but they do have discretion for this upcoming year as we adjust to these new requirements. Let's go to the next. I'm sorry, go ahead.
Michelle, we got a question. Are insurance payers going to be required to provide their fee schedules so that we can give an estimate in the first place?
So these good faith estimates are for self-pay patients. Okay.
Oh, yeah. Okay. Yeah.
And so what they focus on is what HHS has said is when you're making that good faith estimate, they're aware that everybody has their charge master, right? And most of us, and they specifically said 501c3 organizations also have their financial assistance policies that apply to self-pay patients. And you might have a self-pay policy. They expect you to apply those policies because this patient is going to fall within the self-pay payer class. So they expect you to provide that insight And your estimate of fees should incorporate any discounts that would be applicable to a self-pay patient under your policies and procedures. So you're gonna look at your charge master, look at your financial assistance policies, see if you have a self-pay discount policy, and that's what you'll use to set up your good faith estimates. Let's go to the next slide. So the timing of these good faith estimates, let's say that my surgery is going to be at least 3 business days. So I've scheduled it at least 3 business days before it's going to happen. Then the good faith estimate has to be provided to me 1 business day after scheduling. If it's something that's more than 10 days out, so some elective procedure that's more than 10 days out, then we have 3 business days to send them the good faith estimate. Otherwise, if somebody does kind of that shopping of calling you up for a good faith estimate, then if you're a co-provider or a convening provider, then you've got 3 business days to submit it. Let's go to the next slide. So I just included this slide because in the preamble, So on this slide, the good faith estimate must be provided in writing. Even if they ask for it orally, you still need to follow up in writing, and we need to store it in the medical record system. That's explicit in the regulations. So whatever EHR system you have, we need to build these forms into them. Let's go to the next slide. So I included this slide because in the preamble, they were so focused on why they were doing this no surprise billing. And basically, they were saying that under the old laws, so 2019 and 20, patients were receiving services that even if they got an estimate of what the services were, sometimes they were $400 or more above. So if a patient gets a good faith estimate and they get a bill that is substantially in excess of the good faith estimate, which $400 or above, it would be considered substantial, then the patient will have an appeal process where they can go to what's called a select dispute resolution process. Again, those entities will be certified by the government. They will have 120 days after they get the bill from us to appeal it through that process. And of course, we can respond, but that appeal process will be in effect. So once you give the good faith estimate to a self-pay patient, that doesn't mean it's over. If your bill winds up being substantially more, then you may have to defend why it's more in this process. Let's go to the next slide.
So even if it's like a legitimate change of the service, like the example of the question that came in is, I was going to do, vaginal, it turned out to be a C-section. If that's what caused it to be off, what's the resolution?
So if you were going to have normal delivery, but then you scheduled a C-section, they say if changes happen on an item or service that you're going to receive, then they want you to incorporate those changes within a business day of receiving those changes or as soon as practical. So you can update your good faith estimate if the circumstances change or the procedure changes. And just because a patient gets a bill that's substantially more, it'll go through the appeal process. You do have an opportunity to explain why something was more than the good faith estimate. Maybe the items or services that were delivered weren't actually identified in advance, and maybe that was the patient's fault, or maybe it was the provider's fault, but you'll have an opportunity to explain those.
Got it. Let me ask this other question before you get to the lawsuit. How do you factor in your prompt pay discount policy into all that? Or do you have to?
So it's a great question. The only policies that they focused on were those policies that applied to self-pay patients and your financial assistance policy. So if it's incorporated into those and you would normally give a self-pay patient a prompt pay discount, you could incorporate that. But I think that if you're going to do that, you need to notate it in your good faith estimate that this estimate is discounted based on payment being received within so many days. You need to be very clear with the patient because otherwise that prompt pay discount would not apply and you may just not want to include it in the estimate, not knowing if the patient will comply with that provision of paying in that certain time period.
Yeah. All right. I get it. And then the other question that came in on top of the one previous was, so should we just have a stance where we quasi inflate our estimates to take in the what if situations into account in the first place?
I thought about that when I was reading the rules. It's supposed to be a good faith estimate, so I don't want us to inflate it. I think we do need to apply it appropriately, but I think what's critical is in this first year as we're getting into this process is really looking at when we give these good faith estimates, and let's do it based on our charge master and our current financial assistance policies. How far off are we? Like, can we study a random sampling each quarter and see how far off we are from our good faith estimates? because that may impact how we actually calculate those good faith estimates in that next quarter or the next year. And remember, there's enforcement discretion in this first year, so this is the year for us to work out all those kinks. I don't want to artificially inflate anything because it's got to be a good faith estimate.
Ooh, that's rough to then have to put a whole process around it to check it in after the fact. Okay,
Well, I'm just saying if we want to see how we're doing, then that's an audit that you could run through your compliance program to make sure that we're not substantially above our good faith estimates. It's more of a
Understood.
practice just to show, hey, are we in compliance? Do we need to tweak something? Is there a process improvement opportunity here?
That question a second ago about the inflating it, they clarified to say that they're really talking about more emergency surgical situations. And so what do you do with that?
We can't give a good faith estimate on emergency services. So emergency,
What about the instance that there is no network? You and I talked about this. There's a lot of that reference-based junk out there. And when we don't have the chance to contract in the first place, what happens with like an emergency? Well, I mean, I guess not for good faith, but what do we do in that instance where there is no network and they are self-pay or whatever? How do we handle those?
So we've got to look at some of those are actually contracting on behalf of what are considered health plans. They just happen to not contract for in-network providers. And those health plans are governed by this federal law and the state law. I mean, the state law applies to insurers, and the definition of insurers is incredibly broad. So it doesn't include Medicare, Medicaid, or ERISA at the state level. The feds include the ERISA plans, but the definition of an insurer in Georgia law includes any kind of health plan, HMO, anybody who is governed by the Office of the Insurance Commissioner. So if there is a group health plan, they'll be governed by these rules. If there's no group health plan and it's just somebody like a discount medical provider, those DMPOs that are out there, that's really going to wind up being a self-pay patient because they don't have insurance. And so they're a self-pay patient. They're not reassigning insurance benefits to us. And then you go through the good faith estimate part.
Okay, but let's say it's an emergency room visit. We're not on the good faith estimate. I should ask this question before. It's in the instance, it's a Christian, Medishare kind of instance where I'm being arbitrarily paid some percentage of Medicare. The specific question we got was, am I stuck with however they adjudicate the claim and there's really there's nothing I can do about it, or what do I do about those?
I don't think that those are going to fall within the parameters of these laws. So it's back to how we normally handled them before. Because this prohibition of balanced billing relates to patients who are either on individual or group plans, an ERISA plan, or a self-pay patient. And those plans, we'd have to look at those individually, I think, Mike, to figure out how we're going to handle their reimbursement.
Okay.
Because there may be some other ways that we can address if they're paying really low rates outside of these laws that we're talking about today.
Got it. Okay. You need to wrap up, so let me let you go and go ahead and do the lawsuit slide.
All right. Well, I talked about the lawsuit earlier, but I just thought I would include these little notes about where AHA is very concerned about disfavoring the insurance companies. And now we're just waiting to see whether or not they will implement an injunction, and then we'll go from there.
All right. So last question that is on there, since that took just 2 seconds, was it's kind of an add-on to my question from before about if I have somebody that's price shopping. The question is, for patients you don't currently see that request an estimate, how do you provide them with an accurate estimate, not knowing what their issue is going to be? Like a patient says they need knee surgery, but they don't know which knee, implants, all that kind of stuff. What do we do with that?
I think we're supposed to give a good faith estimate for items or services, and that's a specific definition in the rules. So I think it's completely fair to say we need a more definite description of the item or service that you're requesting, because the way the rule is set up is you are giving a good faith estimate for an item or service that you render, and you can't guess what they need. We're going to need more information.
Got it. And then last question that came in, does this also apply to primary care physician offices? I'm sure it would, right?
It does. The way they define healthcare provider is any physician or licensed healthcare provider acting within the scope of their rule. So to the extent that you're not participating, but you go to a participating facility, it does.
Gotcha. All right. Real quick, are there any more questions for Michelle? I know we could probably go all day. And I'm assuming that as you guys get into it in a month or two, you're going to have even a new round of questions because you will have some very specific concrete examples to talk through at that point as well. And so would beg if Michelle could, we'd do that again.
Yeah, I'm happy to do that. We will learn so much more as we get into this.
No doubt.
Assuming that they don't get the injunction. But I want to make sure you guys all get the model notice and consent and the disclosure form. And then just as things pop up, let's just keep those questions and we'll look at the different items.
Gotcha. Well, the last one that came in said, if you didn't provide a good faith estimate, how do you handle the patient billing? Should the patient's bill be adjusted to an amount less than gross? How do you handle that?
You could actually have trouble collecting or billing that patient without there being a complaint filed because they didn't consent to receiving that service. So I didn't see anything about if you don't give it. So basically it'd be a violation of the rule.
Yeah. Okay. And this all is effective 1/1?
Correct. Unless the injunction is granted, it's 1/1.
That's right. And the slides, Aaron will cover in just a second. The slides are going to be posted to our website. Okay. Michelle's got to go. So we're going to have to take a hard left here. Thank you, Michelle. I really appreciate it. Great job. Very grateful. All right. For those of you who can hang on, I will cover it as fast as possible. But we did have something of a COVID update to walk through. Yes, all the disclosures and stuff that Michelle gives us, we'll put out there on the website as well. All right, so hard left from all the no surprises stuff to talking about the HRSA stuff. And so, to the degree you got to jump off or what have you, have at it. To the degree this is of interest, then we're going to go ahead. So what's happened since the last time we've talked, there's been a little bit more. The reporting period for the first round already is come and gone. But there is a new reporting period that's forthcoming right now. If you got any money in the second half of 2020, you have to report. For the money you got then way back at the end of 2020, you have to report on it 1/1/22 through 3/31/22 based on your usage of it through 12/31/21. And I know there are a few of you that got that because the phase 3 money for some of you guys came in pretty quick after the portal opened. And so there's some of you guys that have some money. And so don't forget, you just went through it, but you have a new one to file right now. Next slide, Aaron. So the new funds that have come out recently, and you guys went through the portal for it, and now they funded the vast majority of the ARP rural and the phase 4 money funded. One came in November, one came in 12/16. They're not done with it. So if you didn't get either one of those two, if it's ARP rural, they've distributed 96%. So that may not be that's mostly done. But the phase 4, they've only knocked out 75%. So if you didn't get anything yet, there's still a good shot, or at least a decent shot, you've got some money out there. The attestations were very similar. And they do know that if the application was denied, you should have already been communicated with that it was denied. If there's no news yet, you're in the other 25% and waiting to be distributed and processed. Next slide. Just as a reminder, so where I'm headed in the next few slides is that for those of you that got ARP rural and phase 4 money, you have an appeal mechanism that's coming February the 1st if you can get to a point where you've got a reasonable recalculation of it, that you can attempt to do that and file for additional money. There's a little bit, you'll hear my frustration as we go through this. There's a little lack of transparency in all this that I think is still going to make it a little difficult to do that. But the next few slides, we're going to walk through kind of what their methodology was and talk about how you can get to a recalculation of it. If you remember, the ARP rural was not based on any data that you had to submit. They were looking at 1/1/19 to 9/30/20 HRS data, and they were looking at Medicare, Medicaid, and CHIP data. And basically what they were trying to do was to reprice your reimbursement for Medicaid and CHIP up to quote unquote national Medicare rates. So the base rates at the national level. And then go to that next slide. Then they kind of within the budget that they had to spend, the 8.5, they kind of boiled it all down to the distance between Medicaid and Medicare equals X, and we have 8.5 billion to spend. Therefore, what percentage of that can we send back out to folks? Well, it turned out to be 3%. And so if you're trying to recalculate your ARP rural money, it is they haven't issued the national Medicare number, but we could probably figure that out, the national base rates. Take that versus how you got paid for Medicaid, and then 3% of that number should have approximated it if you can get that close to it. For the phase 4 part, and go to the next slide, Aaron. For the phase 4 part, it was in 2 parts. One was a base payment. 75% was based on the change in reported revenues and expenses that you reported in the portal from 7/1/20 to 3/31/21. And so it was to take that number, and then I'm going to show you in just a second how they tiered it to tell you what percentage of that you were supposed to have received. I'll show you just like that. I'll show that in just a second. And on the bonus payment, it was 25% of it was based on a very similar formula to the ARP rural, except not demographically splitting your Medicare and Medicaid volume as all of your Medicaid volume, regardless of what county it came from, and then flowing through the same percentages. And so go to the next slide. What this one is saying is that it's that difference over that 9-month period for whatever loss you incurred that you reported through the portal. And then it went through this chart. You were considered small if you had net revenue of less than 10 million, medium 10 to 100, large over 100. And the resulting percentage that you were supposed to be paid was 45% of the difference, like operating revenues minus expenses in the base period, revenues minus expenses in the new period, take the difference, and whatever the hit was, 45% of that. The caveat is that it reads to us like all that second bullet point with the please note that it reads to us like the prior funding was prior payments were deducted at that point. And so if you're one of we've talked to a whole bunch of you guys who thought that your phase 4 payment was going to, and we thought that the phase 4 payments were going to be a lot higher. I think it's because they're deducting the entirety of what you got in the prior rounds against that in order to point more of the money at the providers who didn't get much, which is generally the independent physician practices got way less than the hospitals for the prior rounds. And so I suspect that's what the disparity is. But we need to go back and recalculate a few to show that. Go to that next slide. The phase 4 for new applicants was based on go through that base payment calculation from before. Because you've received no payments, it's the greater of 2% of net patient revenue, which was what their baseline was in phase 1 and phase 2. And then versus the calculation on the prior slide, there wouldn't be anything to take out, and that just would be what you got if you happen to be a new provider in 20 or 21. And then the step 2 is, like I was saying a minute ago, it looks like they're offsetting all of the prior phases of funding from this calculation, in spite of the fact that it's different timeframes, which looks weird to me. We don't have it verified in an FAQ, but the really odd wording in there that makes it look to us like everything a hospital got in all the previous rounds kind of went against this methodology, which may be, again, is why I'm suspecting a lot of the hospitals, for example, didn't get near as much as we were expecting. Phase 4 methodology, calculating the bonus payments. The first section at the top is just a reminder. Go to that next slide, Aaron. I'm sorry. The top 2/3 of the slide is basically just saying that it replicated the ARP methodology, like I was saying a second ago, except excluding the demographic requirement for it to be rural. But that last payment, that last point, I mean, is kind of the key, that the bonus point methodology. However, utilizing, it's the same. Once you calculated that difference this time, rather than it being 3%, it was 45, 25, or 20, depending on the size of the hospital, which again, also probably justifies why some of the other guys got a little bit more money than you were expecting of the independent physicians. Next slide. All right, this is what I was sort of saying all this was driving to. And I know I'm not giving you enough information to go recalculate it on your own. Come January, we need to be having specific conversations around this. But the upshot is that the reconsideration portal will open 2/1 and will be open for at least 45 days. They're very specific to say they're not gonna, you can't submit a new application if you miss the deadline. They're not going to be able to revise, you're not going to be able to revise or correct the original application material, and they're not going to accept reconsideration requests that change the overall methodology in the first place. The only thing you can do is recalculate it based as best you can figure out what it should have been, flow through what should have been deducted from prior rounds, and then look at what you got paid in phase 4 plus ARP rule, and see whether or not that number looks right. And then if I would assume if it's significantly off, then that's when you would be applying for additional funding. That next slide. Editorial comment, which I've been giving you throughout this, is that given the internal factors that they haven't released, it's going to be tough to get enough transparency. It would be really helpful, for example, if they would release the national Medicare rates that they're using. And whatever the definition is, for those of you that have variable rates and are not a prospectively paid mechanism, rural health clinic, critical access, and there's other types of you out there that have variable rates based on the type of entity that you are, or the type of department within your hospital, that's how it's reimbursed from Medicare. It's variable, and so they need to clarify what that would be in order for you to recalculate it for them in the first place. And then my other point I keep beating in the ground about the fact that all the prior payments came out, and it looks like regardless of whether or not it was for the same time frame or not, because you're dealing with a pandemic that is a much longer time period than the 9 months that were in question on that last portal. And yet it appears that they're taking back, or they're pulling back out of your final answer everything you've gotten from the past. And so we suspect that we're going to have to start watching FAQs again and submit some on our own to answer some of those questions around all that. So I think that's it for that one. Does anybody have any questions related to that piece of it? All right. There were a couple of more questions that came in on the chat. Michelle has had to go to another meeting, and so I would suggest that we can push those questions back out to you guys in a group email or post them on our website one way or the other. And so we'll get those questions answered and submit them to you. Sorry for drinking out of the fire hose today. I know that was a lot. Aaron, back to you, buddy.
Alrighty, thank you, Mike. I will take these questions and make sure Michelle gets them, so we can get some answers for y'all. But to answer some of the other questions, yes, this will be posted to our website. Hopefully this afternoon, with the holiday pending upon us. It hopefully won't be delayed. I say hopefully because we all know how that goes. But this is the conclusion. If you do want to head to our website, shpllc.com/webinars, that is where we will post the slides. It's also where we'll post the recording as soon as it is available. So everybody have a very Merry Christmas and a Happy New Year. Stay tuned for our next webinar.
Thank you all.